Should we start?
Yeah. Good evening, one and all. Welcome you all to another webinar conducted by Clinical Infectious Diseases Society, CIDS. CIDS is a society comprised of infectious disease physicians, physicians interested in infectious diseases, clinical microbiologists, and other like-minded clinicians interested in the field of infectious diseases. It has been in vogue for more than 10 years. Our premier academic event is CIDSCon. Last year with COVID, we had hosted a series of CIDS webinars to enlighten the Indian physicians on the latest happenings in the field of COVID. And we thought that COVID would be no more. And I think right now we are in the second wave of COVID in India. And with that, we had earlier in a webinar on COVID vaccines. And now we have on the latest updates in the field of management of COVID. And today's session will be for 2 hours. We have 3 lectures of 20 minutes duration. And at the end of each lecture, we would have 5 minutes for questioning. And then we have a panel discussion for 45 minutes in which Dr. Kavita will be hosting the panel discussion, and we have 3 different panelists. And this event will be streamed live on YouTube. People who would have not had access to Zoom can watch it in the YouTube. All you have to type is CIDS webinar, CIDS, CIDS webinar, and Zoom attendees, people who have already registered, will have their links emailed to them. And all they have to do is to click the email link. With that introduction, and then let us go ahead with the proceedings for the day. The latest buzzword with the second wave happening is variants, mutants, all those things. For an average clinician like me, this looks like, sounds like Greek and Latin. To simplify it further, for an average clinician, Indian clinician, we would have Dr. Tanu Singhal, who is a senior consultant in the field of pediatrics infectious diseases based at Mumbai. She was one of those early batches to be trained in the field of infectious diseases from Hinduja Hospital, Mumbai. And she's been very helpful and resourceful faculty for this CIDS webinar events. And I should thank all the faculties, because all I had to do is to just send them a message, WhatsApp, not even give them a phone call. And all of them have accepted within a very short notice. All of them were contacted just 5-6 days ago, and all were kind enough to oblige and then get ready with their PowerPoints. And with this, let us start the proceedings. The first talk would be on variants and mutants, the global scene, and then what is relevant to India. Off to Dr. Tanu Singhal.
Thank you, Dr. Nambi, and thank you for this opportunity to talk about this important topic. So is my screen visible? Hello?
Yeah, it's visible. Please go ahead.
Okay. Yeah. So I'm going to be talking about this SARS-CoV-2 mutants, variants, and what's up in India. So, we come across various terms in our day-to-day practice, and I would first like to simplify it for all of you. So we know that all viruses mutate regularly during replication. And RNA viruses lack a proofreading mechanism, unlike DNA viruses, and hence they make more errors during replication, and therefore more mutations accumulate. And we all know about the influenza virus, that how many mutations happen and how our vaccines have to change every year. When we look at coronaviruses, it has one of the largest genomes of all the RNA viruses, about 30,000 nucleotides, and they also possess some repairing enzymes. But still they mutate, and especially when the force of transmission is high, when there is a lot of transmission happening, and sometimes when there are people with partial immunity, that is when these mutations accumulate even more. And because of these phenomena of regular mutation of the virus, it leads to different clades or lineages of the virus, which is different from the ancestral virus. So, we all say that the earliest ancestral virus was the Wuhan virus, and then there were these clades which came and these lineages which came, and we will discuss them later. but that is what clades and lineages mean. And also what happens during this time is that if there are mutations that provide transmission advantage, they are selected, because out of the theory of natural selection. So if there is a virus, a mutant virus, which is highly transmissible, it soon out dominates the other previous strains. And sometimes, if and some of these viruses may also possess more lethality. And when there is either a significant single mutation which changes the structure of the virus so much, or if there are multiple mutations which accumulate, it leads to a variant. So that means all mutant viruses are not variants. And when this variant has different phenotypic characteristics from another COVID-19 virus, it is co-termed a strain. So basically, the terms variant and strain are often used interchangeably. And how do we know that all these things are happening? Because, there is a whole genome sequencing of the virus which is going on since the pandemic began. And different people all over the world, upload their sequences on a global database, which is the GSAT database. And that is how it is believed that now there are several 100,000 genome sequences which are uploaded to this database. Now, before we go ahead, we need to understand a little bit about nomenclature. So for SARS-CoV-2, there is a standard nomenclature of clades, which is called as next strain nomenclature. And it is important to know this because when we talk about variants, we refer to this. So basically, you had the earliest virus, which was 19A. 19 means the year which the virus was discovered, 2019. And then it had two clades, 19A and 19B. And remember, about a year back, we were talking about the L and S type. And then the L type went away, and then you had the 20A, which is the virus which then spread throughout the world. And then this 20, because it was discovered in 2020, and then A. And then further it gave rise to other clades like B and C and D and E, F, G, H, I, J, and so forth. And actually, if you look at the phylogenetic tree which is uploaded on Nexttrain, you can see that as time has gone by in the past 1 year, you have different types of viruses emerging at different times. And all of these are the different clades which you can see here on the top. And then if you look at this figure, you can see that the initial viruses have now been, like 90 days not there, and you have different viruses and there are new ones which are coming up. So that is a regular phenomena which happens. So this is one nomenclature. But to confuse issues further, you have basically, the other nomenclature, which is the pangolin. Now, initially I thought that pangolin refers to that intermediary host which was responsible for transmission of the virus from bats to humans, but actually it is a short form for phylogenetic assignment of named global outbreak lineages. And this is just to say that they have a different system, because they first start with the A, which is the parent virus, and then it goes on to a different virus, which is B. Then you have B.1, then you have a different virus which is named as B1.1, then you have B1.1.1, and then finally, when it comes 4 ones, it gets converted to C. So this is another way of nomenclature, which is the pangolin system. And actually, both these nomenclatures are used when we are defining variants. And if you see from this basically global graph, you can see that most of the lineages right now are either B1 or its progeny, which are there. And then, you have certain other lineages like D, which is there in Oceania, etc. So basically, these keep changing with time. Now, there is one other concept which we really need to understand before we go further, and that is about the SARS-CoV-2 genome. So this genome, as I said earlier, has 29,000 nucleotides, and it basically has the most important part of the genome is this part which codes for the S protein. And then you have the other parts, like these are the open reading frames which code for the non-structural protein. And you have the other proteins like the nucleocapsid protein or the membrane protein or the envelope protein. So it is believed that the mutations which affect the gene coding for the spike protein have the greatest consequence. And we need to understand a little bit more about the spike protein. So you see, this is the spike protein, and this spike protein is composed of two parts. There is an S1 part, which is the one which binds to the ACE2 receptor, and there is the S2 part, which is the branch. So when the virus comes and attaches to the ACE2 receptor, after this, there is a phenomena in which this S1 and S2 units are cleaved by the host proteases, and which then allows the virus to enter the cell. So in terms of entry of the virus, both the S1 and the S2 unit have an important role to play. And this is the better depiction of the S protein, because it is not as simple as it looks here. And you can see here that it is all merged together. And this is the most important point, which is the receptor binding domain, this blue thing that you see here. So what happens is that when the virus is about to attach to the ACE receptor, this RBD opens up and it binds to the ACE2 receptor. And then, of course, the cleavage and other things happen. So, so basically, those genes which affect the structure of the receptor binding domain cause major changes in the transmission ability and even the neutralization of these viruses. So with that knowledge, we should come to the nomenclature of the mutations and variants, because you will come across this again and again. So for example, each mutation is basically, it can be either a substitution or a deletion. So in a substitution, basically an SD641G means that in the spike protein, the position 614, there is a change from aspartic acid to glycine, because for all of these amino acids, you have one letter codes which are available. So these letters D and G basically mean what amino acid substitution has happened. Similarly, there can be deletions, and this means that there is a deletion of amino acids at position 16 and 69 and 70 of the protein. So when you talk about variants, the variants are named like by the next strain. It's the clade, which is followed by the main mutation. So for example, this is the variant or the UK variant which we know, and it is basically the parent clade. 501Y means that there's a mutation at the position 501 where N has changed. N, which is basically asparagine, has actually changed to tyrosine, and V1 because this is the first variant which was discovered in the UK. So you can use this nomenclature based on the parent clade, or you can use the Pango nomenclature, which is based on the lineage. So that is why when you see the variants, they are named, both names are given. So with that understanding of the nomenclature, let us come to the variants of interest, which are the variants which are under investigation. But a variant of interest becomes a variant of concern when either it is more transmissible or infectious, or more lethal, or it escapes immunity, which is conferred by either previous infection and causes reinfections, or it can escape the immunity provided by vaccines. If it can reduce the efficacy of drugs, and particularly the monoclonal antibodies, the Regeneron and the other monoclonal antibodies which are used in the US and other countries, or it can reduce the sensitivity of PCR tests. For example, if the PCR targets the gene in which the mutation has happened, then the PCR test cannot detect it, such as which happened with the UK variant. So if we talk about the timeline of variants, then the first variant which came was in February 2020. And this was basically the first variant, which was basically a single mutation in the gene which was coding for the spike protein, where there was a separation, substitution of aspartic acid to glycine, and glycine being less bulky allowed it to bind better to the ACE2 receptor. And now we know that this is more transmissible than the original virus, but it is believed that it's not more lethal, and it is still susceptible to the vaccines. And interestingly, the mRNA vaccines were made using the original strain and not this variant, whereas Covaxin was made using this variant. And then there was this mink variant, which came into being in August, September 2020, because there was an outbreak in farmed mink in Denmark, where there was a specific mutation in the spike protein, and it was believed to be more transmissible. But luckily only 11 human cases were reported. And as a consequence to this outbreak, 17 million mink were culled. So we must remember that this development of variants or mutations does not only occur in humans, it can occur in animals, and then these mutant viruses or variant viruses can get transmitted to humans as well. And then let us come to the current variants of concern. So we all know about the UK variant with this nomenclature, and it has 17 mutations, and the main mutation is this N501Y, which is basically the mutation in the receptor binding domain of the spike protein. And it is now proven that this is 70% more transmissible. And basically, this is what happened in the UK, that in December, they started seeing such a surge in cases that they knew that there was a more infectious virus. However, the good thing about this variant is that it does not usually cause reinfections. It does not impact the monoclonal antibodies, and it has minimal impact on the protection offered by vaccines. And that's why the AstraZeneca vaccine continues to be effective in the UK, where this strain is widely circulating. Then you have the other variant, which is basically the what we commonly known as the South African variant, which came into being since August. Again, it has that same mutation of the UK variant, but apart from that, it also has the E484K mutation, which is an immune escape mutation. It is, while being more transmissible, it also is able to evade previous immunity, and therefore it can cause reinfections. It does not really, monoclonal antibodies don't work well against it. And the other major consequence of this mutation is that it impacts the protection offered by the vaccine. So, in fact, the impact on the AstraZeneca vaccine is very severe, whereas there is a moderate impact on the Janssen and Novavax vaccines, whereas the Pfizer and the Moderna vaccines are still effective in the lab for this virus. Because remember, when these two vaccines were tested, this variant was really not around. So we can't know how did these vaccines do against the South African variant. And then you have the Brazilian variant, which is also very closely related to the South African variant. It again has the same mutations as the South African variant. And again, it is also can cause reinfections, and it can also impact the protection offered by vaccines, because it was seen that both the Janssen and the Novavax vaccines had lower efficacy in Brazil as compared to the US. And then you have now the California variant from the US, which is again, there are two types of lineages here, again, which is believed to be more transmissible. And also, it is believed that it can, impact the protection offered by the vaccines. However, this variant is not circulating outside the US in large amounts. And this is a graph which tells you what is the current status of variants in the world. And if you look at V1, which is the UK variant, this is the variant which is quite prevalent in Europe, and it is also found in India. Whereas if you look at the South African variant, which is V2, it is mostly in South Africa. And if you look at the Brazilian variant, it is mostly in Brazil and other countries in the South America. So what is the situation in India? So coming to the Indian situation, the ability to detect variants depends on how much whole genome sequencing is happening. So, for example, UK detected the variant because it was sequencing 5 to 10% of all its isolates. And so also over countries like New Zealand, Australia, etc. But when you look at India, the sequencing is so low. So even if these variants are circulating, we won't be able to detect them. And that is why India launched this genomics consortium called INSACOG, which linked 10 labs together, the function of which was to basically try and, sequence more isolates so that we know what is the current situation of variants in the country. And this is the latest, download which I did from the Indian genome data sets, which is available on the CSIR website. This is the address where you can see that over passage of time, there has been replacement of the clades. And if you look at these variants, like this is the UK variant. It is the UK variant is coming up. This is the green one. And then you also have very few cases of the South African variant and just a few cases of the Brazilian variant, which have been detected, but this is only till February. And in fact, you have a press release which talked about these variants in India. And they sequenced about 10,000 samples of total 12 million cases. So that is only 0.1% of the total number of cases. And all these samples have not been collected recently. They have been accumulated over the past 6 to 9 months. So they may not give a true picture of what is happening now. And out of these 10,000 samples, 771 have shown variants of concern, mainly the UK variant in Punjab. And but more important than these variants are the new mutants which have emerged in India, which is basically there are two variants or mutants which I need to talk about. One is the N440K, which is again in the spike protein identified in Telangana and Andhra Pradesh, and it is associated with high transmissibility. And then you have the double mutant in Maharashtra with these two mutations in the spike protein. And if you look at this mutant has already been given a lineage, though it has still not been called as a variant of concern. And it has one gene from the California variant. This is L452R, which is even believed to escape the effect of the T cells. And this is the E484Q, which is similar to the mutation in South Africa and Brazil. And if you look at this phylogenetic tree again, this lineage is mainly present in India, because pink is what is India and the rest are the other countries. So 70% of these double mutant have come from India. So the final question is that are these variants and mutants the cause of resurgence of disease in India? Because all of you know we are going through a second wave. The number of daily cases is even more than what was seen in the peak of the first wave. And slowly our deaths are also inching up every day. And now we are at about 700 to 800 deaths per day. So what is the reason for this resurgence? So if you look at the point which is by the in charge of the CSIR, he says that the rising cases are because of carelessness of people and not due to mutations. But I would like to differ from this viewpoint. I think there does seem to be a variant virus, because these precautions which people are not following have been down since November of last year, but we didn't really have cases for 2 to 3 months. The other thing which we are seeing in this wave is that all family members are infected, suggesting that infectiousness is high. So earlier, we had in the first wave, one person would get infected, a couple of other family members would get infected, but not all. Now the whole families are infected, means that the virus is highly infectious. Also, we've had many healthcare worker infections who were working through the previous year in close contact with COVID patients, not getting infected, and now are getting sick. And some of these healthcare workers did not take the vaccine actually because they had, the problems, they had fear of the vaccine. Then, as a pediatrician, I'm seeing more and more children getting infected, whereas that was not during the first wave, and they are now becoming sick. They have fevers which last for 3 or 4 days. Fortunately, most of them don't require hospitalization, but now more and more are also getting hospitalized, which never happened in the first wave, unless they had that multi-system inflammatory syndrome. We are also seeing young patients becoming sick. So that is a difference. Even in the UK variant, it was seen that young patients were becoming sick. And also, we have had many infections in healthcare workers, and you've been reading through that, there are doctors who have got infected despite taking 2 doses of the vaccine, though these infections are mild. And of course, we say that the efficacy of the vaccine is at best 70 to 80%, but clearly we are seeing more breakthrough infections even after 2 doses of the vaccine. Also, we are seeing reinfections. We've seen 5 or 6 cases of healthcare infections in workers, and mutants have been identified, like the double mutant I talked about earlier. So I think with that, I would like to summarize my presentation, say that it is the nature of the virus to mutate and thus survive. And even before the mutants and variants arrived, it was anticipated that they would come. And it is now a reality that they are here. And these variants are the reason that there have been surges in various countries, and have also led to reduction in vaccine efficacy. And we are staring at the same situation in India at this time. In Mumbai, there are no beds available for sick patients, and the deaths have now are almost same as what we had in the first wave. Because early in the second wave, we were thinking that it's a milder wave, and people are not getting sick, but that's not true as of today. So the need of the hour is basically to carry out extensive whole genome sequencing of representative samples, and especially sequence those isolates which are in people who have received 2 doses of the vaccine or those who have had reinfections. We have to have strict masking, social distancing, and maybe partial lockdowns, because otherwise the healthcare facilities are being overwhelmed. And also, we need to ramp up vaccination against COVID-19, because even with variants, vaccination does reduce disease severity. So that is a phenomena which we've seen here, that if people have been vaccinated with at least one dose more than 3 weeks earlier, they are not coming down with severe disease. So even though the vaccines may not work completely against the variants, they do offer some protection. And because we really don't have anything else also to offer people. So with that, I would like to end. Thank you so much.
Thank you, Dr. Tanu, for making a difficult topic a simple one in a nutshell. And I know that you were very busy and you had prepared it in a very short notice. Thanks a lot. I would just have only one question. Dr. Shekhar Mayani is asking, what is your opinion on impact of vaccine efficacy in mutation that occurs in S1 gene region?
Yeah, so it does seem to reduce the efficacy, because if you look at the South African strain, and if you look at the this strain, Brazil strain, they were getting affected. So these spike proteins, the S1 subunit was getting affected, and it led to reduction in the vaccine efficacy.
Thank you. And Dr. Rajalakshmi wants to know whether do you send all samples of reinfection for sequencing? If so, then how do you do it? Is it easily done in your setup in Maharashtra?
Yes, so in Maharashtra, we have to inform. So if we have a case of reinfection, we have to inform, and they do take the sample from us. Of course, we don't have the previous sample archived with us, but the new sample we send. And also now, as part of collection of data, whenever a person fills a form for the, for the COVID-19 testing, they have to write down their vaccination history as well. So that information is also being collected.
So it means that you would not be allowed to send it independently. You have to get the permission of the local health authorities and get it done. Is that the...
Yes, because we send it to them only. They only collect it from us.
They only
And there
collect it.
have been times when they have randomly asked us to provide isolates as well. So that has also happened. So they have asked us randomly as well. But we can't independently send it for sequencing because we don't have a place where we can send it to.
Thanks, Tanu. And Dr. Shekhar Mayani, for the benefit of audience, he is letting us know that the variant detection, even though it is mainly performed by the whole genome sequencing, but he's letting us know that currently PCR-based kits are available in the market, which would be able to detect the UK, the South African and Brazilian variants. Yeah, that is what he's letting us know. Probably, I think we should, I'm not aware of that. Probably if it is aware, then probably it will be much more easier for us to have access to these variant detection. And with that, I think we will conclude this talk. Thanks once again, Tanu, for taking your time on a busy day to give us this enlightening lecture. And then we would go on to the next lecture by Dr. Ram Gopal Krishnan. His topic would be on COVID-19 treatment update, what is in and what is out. And I think this is one area which exposed the frailties in the clinician mind in terms of treatment decision. I think all of us will have come through a full circle in what we used and what we are using now and what is in, what is out. Dr. Ram Gopal Krishnan is a senior consultant in infectious diseases, and probably I think he's the first American board certified ID physician in this country. And he's my teacher, and he's a very passionate teacher. He is the academic director of the Institute of Infectious Diseases, Apollo Hospitals, Chennai. And he would be giving us this current update on COVID-19 treatment in the year 2021, what we should be doing currently. After Dr. Ram Gopal Krishnan.
Okay, thank you, Dr. Nambi. I hope you can see me and hear me well, and the slides are visible.
Yeah, please go ahead, sir.
Okay, right. Okay, so this is what I've been asked to do. These are my conflicts of interest. It is mandatory to show one of these slides in this day and age. There you go. And so as far as as far as possible, CIDS has asked me to do this lecture twice, once this time last year and once at CIDSCon. And I tried to retain my slides as much as possible, just cross off what doesn't work and put in what does. Now, initially, my slide said too few randomized controlled trials. We were just going by hocus pocus, case series, and all that. But now we have some excellent RCTs on which to guide therapy. And we are getting better at treating COVID. This is a US study which showed that when they applied evidence-based medicine, they actually reduced their inpatient mortality by half, given the quality of the data available. Now, one thing we're realizing is the window of treating SARS-CoV-2 is pretty low. If you want to use an antiviral, by the time they're symptomatic, you've lost most of that window. And so by the time they present you, you're stuck with immunomodulating the patient. So this is a problem in terms of antivirals. You have to have something that works right at the beginning here, or you're just stuck with reducing the inflammatory response. This is a problem fairly unique with this virus. So this was my slide, which I had last year. You throw whatever you had at it, because at that time it was totally untreatable. Let's see where we stand with this huge cocktail. In terms of antivirals, these are some of the antivirals that have been tried against COVID. I have restricted the number to these. There are many more, obviously, but I have restricted to these. Let us see how these have stacked up over time. Now, in terms of hydroxychloroquine, we have excellent data. The UK has contributed the recovery trial to the world. This is a huge trial which randomly assigned many patients to different arms of care. It is a very practical trial. And to summarize, the first thing that came out was hydroxychloroquine does not work. There was clearly same mortality, if not more, in those who received hydroxychloroquine. Some criticism in that the doses used were high, but this is really level 1 evidence that said that if you're sick enough to be admitted to the hospital, hydroxychloroquine does not work. The Solidarity trial was WHO's equivalent to recovery, as big a trial. And you can see here that big numbers and showing that hydroxychloroquine and its control are virtually superimposed on each other. So this reaffirmed in what recovery said: if you're admitted to the hospital, hydroxychloroquine does not help you. This was a smaller trial published in JAMA. And again, the adjusted odds ratio was 1.02. So these are all excellent quality trials, randomized controlled trials, which shows that there is no role for hydroxychloroquine for hospitalized patients. What about if you started it early, perhaps with or without azithromycin, mild to moderate COVID? This study in the New England Journal, again, did not improve clinical status. There may be a role if you start these drugs very early, but at least the randomized controlled trial, this one in the New England Journal, another small one, showed no benefit here as well. However, is it a numbers game? Perhaps if you analyzed enough patients, they put together all the trials on ambulatory patients who got hydroxychloroquine, and this meta-analysis suggested that there may be a benefit in terms of COVID-19 hospitalization or death. Once again, maybe it's subject to all the flaws of a meta-analysis. So really, nobody recommends hydroxychloroquine currently. In hospitalized patients, you can be very, very clear that there's absolutely no role. And there's also a drug interaction if remdesivir is given. So nobody uses it in the hospital. And I can't think of anybody who really gives this drug to outpatients as well. So what is the role of this drug? The US actually withdrew their emergency use authorization. WHO says it doesn't work. So really, hydroxychloroquine can be given a formal burial in terms of COVID. Now, initially in the epidemic, people added on azithromycin. That was really a strange one. Why would you want to treat a virus with an antibiotic? Perhaps for azithromycin's immunomodulatory properties. It did not work in this large RCT in Brazil. And the recovery folks, once again, came to our rescue on this point as well, clearly showing that the azithromycin arm of recovery showed absolutely no benefit. So azithromycin died a quick death as well in terms of COVID treatment. Now, lopinavir-ritonavir was very popular on most treatment guidelines at around this time last year because it was a readily available protease inhibitor, a repurposed drug. And again, the recovery trial showed that there was no mortality benefit at all with lopinavir-ritonavir. This was shown in the initial New England Journal trial, but in a proper, bigger trial, it really did not help. And Solidarity confirmed what recovery said. You can see that these two lines virtually superimpose on each other, and the diamond is across the median. So lopinavir-ritonavir is no better than placebo, and that drug really is no longer used for COVID anymore. So what are we left with? This parenteral drug. It's a big problem because this is a parenteral drug. It mandates often hospitalization just for giving the drug, which is a problem. The initial ACT2 interim report and then the final report was just published in October last year. What did it say? You got better quicker. You got better about 5 days quicker. We'll talk about the O2 requirement. Fewer side effects if you got the drug as opposed to that with placebo. Trend towards, but not significant mortality. This number was not statistically significant. And again, it helped only if you started it early. And really, for it to work, you got to start it really early. Only 25% of patients in this trial got it really early when it would make a benefit. And strangely enough, this worked in only one oxygen category band, the one in the middle. You're in the hospital, you required some oxygen. Doesn't help if you had mild disease, certainly doesn't help if you have severe disease. EUA was given and formally approved in the US last year. These are the curves showing that if you received, say, 1, 2, 3, 4 liters O2, you're okay. This drug help you get better a little bit quicker. Doesn't prevent you from dying, but help you get better quicker. Certainly doesn't help if you're seriously ill. This is probably too late in the disease, and doesn't help as well if you're too sick. If you're not on oxygen, really no mortality benefit. This trial looked at remdesivir in hospitalized patients who did not require oxygen. Your saturation had to be good. In other words, did it make the fever go away quickly? Did you feel better with remdesivir? And the 5-day course, according to the investigators themselves, did have a statistically significant difference, but uncertain clinical importance. So really, when, what do you do? If your oxygen saturation is good, this trial shows that it really didn't improve clinical endpoints a whole lot. So what is the role of remdesivir? We'll discuss that when we finish the other trials. Now, the big one in this area was once again Solidarity, which looked at remdesivir and clearly showed absolutely no benefit in terms of mortality. Remember, Solidarity was a mortality study, no benefit. Remdesivir clearly does not save lives, whether you were ventilated or not. In fact, if you were ventilated, there was a suggestion that mortality may go up, not statistically significant. So seriously ill patients, remdesivir does not seem to work. Obviously, this trial looked at various other drugs as well. Hydroxychloroquine, we discussed. Interferon, this was not statistically significant. Lopinavir, we discussed. So this was a huge negative trial, a huge trial. Unfortunately, it did not throw up any answers on how best to treat COVID. And looking at all this, WHO, having cost, looking at developing countries, etc., had a conditional recommendation against adding remdesivir. They said, don't give remdesivir. This is somewhat at odds with what Western guidelines would say. So this is the summary on remdesivir. It does not save lives. It does improve oxygenation and reduce hospital stay if you give it early, even in steroid-treated patients. So perhaps a marginal role for this drug. What about Desi remdesivir, which is favipiravir, which was the soup of the day for quite a while last year? Unfortunately, the quality of trials is quite poor. You just have this small study, pilot phase 2, phase 3 study from Russia, poorly studied, criticized, really can't draw any conclusions from this trial. But this was a better study published out of Mumbai. This was, however, a company-sponsored study, which looked at favipiravir, 150 patients. The primary endpoint there was viral shedding, and that was no different. So the primary endpoint actually failed. There was perhaps some difference in time to clinical cure, but far more adverse events compared to control patients. These were the problems with this trial. You can see here, many were asymptomatic. Why would you want to give an antiviral to an asymptomatic patient? So a lot of problems, and really, I don't see a role for this drug. It's fairly expensive, huge pill burden, does cause side effects, no proof that it prevents progression to hospitalization or prevents requirement for oxygen. So we have never used this drug in our practice. What about ivermectin? Now that is tempting to use because it's readily available, works well for strongyloides and for some filarial infections. Now early on, however, the PAHO put out a notice saying that if you want to use this drug in humans, you'll have to use huge levels. The levels at which it works need to be far higher for it to be effective against SARS-CoV-2 in cell culture. So this was a problem in terms of dosing. The standard 200 micrograms per kilogram dose probably is not enough. But this seductive meta-analysis came out putting this diamond well to the left in favor of ivermectin. But when you read it closely, there was a lot of criticism of the data. In other words, rubbish plus rubbish plus rubbish equals rubbish. So a lot of poorly done studies, and really you can't conclude. RCTs are in progress. The most recent iteration of the WHO guidelines suggests don't use this drug unless you're doing a clinical trial. So ivermectin, as of now, is still a drug waiting for a disease. However, we do use this drug when we give patients steroids to prevent strongyloides infection, not for COVID, but if you're on dexamethasone, you could reactivate strongyloides. A single dose is not unreasonable. So all the antivirals, unfortunately, have been struck off this list. And this is really a felt need in COVID science. We don't have a good, effective antiviral. There's even oseltamivir with all its flaws for influenza, but we don't have a good oral oseltamivir for COVID, which we can give for outpatients, or even a good, powerful one, albeit with side effects. We need a better one than remdesivir for more severe COVID. So this is a big problem in COVID therapy. So since the antivirals don't work, can you subvert the body's immune system to take care of the virus? These are the three interventions in this area. I won't talk a lot about interferons because this is the old Lancet study, which was inconclusive. There's no further data. We will talk about convalescent plasma. This was a noble thing to do. It's payback time to society if you got COVID. And this was the initial trial, which was actually a negative trial. This was published in JAMA last year. However, convalescent plasma was very popular around this time last year, even though historically, if you look at the history of medicine, for instance, pneumococcal pneumonia, it worked well only when instituted in the first 3 days of symptom onset. I've almost never had a patient come in within the first 3 days of symptom onset. And the reason for that is by the time they come in, they have formed their own antibodies, which is probably in higher titer than anything you could give in terms of a therapeutic intervention. So if you already have antibodies and you're not improving, there's not a good chance that you will improve when you get somebody else's antibodies. However, India contributed to the literature. This is an excellent trial, actually. It's a model for all trials. The PLACID trial, which was done by ICMR, it's a large open label phase 2 multi-center randomized controlled trial. What did it show? It showed no benefit, no mortality benefit, no reduction of progression to severe disease. However, note that patients were enrolled about 8 days out. Roughly, it takes 5 to 7 days for your antibodies to start producing. So naturally, it was a negative trial as could be expected, and therefore this is no longer popular in India. There was a much bigger trial coordinated by the Mayo Clinic where they looked at 35,000 transfused patients. This is not a randomized controlled trial. They just looked at the relative risk of mortality in patients who got high titer versus low titer COVID. And they sub-studied some 3,100 out of those 35,000 patients and published this in the New England Journal. To give plasma, you got to give high titer plasma. Naturally, you need lots of antibodies in there. And there was benefit. And again, you got to give it very, very early, within 3 days of testing positive. Very tough to catch these patients that early. And obviously works only if you give them early before they progress to mechanical ventilation. So plasma has been fairly well teased out. That's what we thought. This study from Argentina was another RCT which did not show benefit from plasma given in the conventional way. And the meta-analysis also suggests really no benefit from plasma. So certainly plasma given to your average hospital admitted patient is out. But if you have a patient who comes in very early, this was a trial which showed that if you come in within 72 hours, and if you're at high risk, older patient, high risk, within 72 hours, then yes, you could get some benefit from plasma. This is a difficult concept to implement because it would mean virtually treating patients out of the community with almost like a blood transfusion with all its attendant risks. So currently doesn't work if given late. The EUA is now limited in those who don't have humoral immunity, like B-cell impaired patients. Certainly doesn't work if you get intubated. You could think of it as the poor man's monoclonal antibodies. And what are the rich man's monoclonal antibodies? We have these very expensive drugs given parenterally. High risk, wealthy patients are candidates. You have to give them parenterally early as an outpatient before the antibodies form. So the way this works is if you're in a high risk category above the age of 60, lots of comorbidities, you go in as soon as you get COVID diagnosed to an infusion center and you get a shot of this, once the patient is hospitalized or hypoxemic, it will not help and may actually harm. The product insert actually says that. There are 3 of these available with 1 more on the way. The combination of casirivimab plus imdevimab was given to ex-President Trump. In outpatients, yes, there was a benefit. It does have an emergency use authorization. Nobody recommends this as standard of care, but a clinical study to treat severely ill patients has actually been paused. The product made by Lilly is bamlanivimab. This is a monoclonal antibody, but the one thing you have to remember about bamlanivimab is what Dr. Tanu told you. These new Californian variants have outsmarted this drug. They are more transmissible and not as responsive. So they've officially stopped distributing this monoclonal antibody product. This combination antibody product is still thought to work well. Again, has to be given very early. So once again, really difficult to get high-risk patients for a parenteral infusion early after diagnosis. So monoclonal antibodies are all we have left. Interferons, no proper data. Convalescent plasma is virtually gone. So we are striking out in this area as well. So what about the immunomodulators? This area has taken a sea change since April last year. Certainly, these are some of the products that have been used. There are many, many others which have far less data. Dexamethasone, this is probably the most important COVID trial published so far. The dexamethasone component of recovery, clearly this benefited, this saved lives. So the first thing, something saved life, 41 to 29% mortality if you were on the vent, 26 to 23 if you received oxygen. And therefore dexamethasone became standard of care. You can look that the more severe you were, the greater your benefit was from dexamethasone. And some suggestion that if you were an outpatient or if you did not require oxygen, then dexamethasone might actually make you worse because you're allowing a virus to multiply when it's not doing much damage without a proper antiviral on board. So again, not statistically significant, but this was actually talked about in the original article. Now, once recovery was published, other steroid RCTs obviously had to be stopped for ethical reasons. Hydrocortisone, dexamethasone, all of these had to be stopped. There was one trial from Brazil on methylprednisolone, which did not help these patients. There were some reasons peculiar, which was started pretty late, etc. But the JAMA people did a meta-analysis of all these stopped trials, and they clearly found that dexamethasone is helpful for COVID. When you put all the trials together, so is hydrocortisone, perhaps not so much methylprednisolone, but overall steroids lower all-cause mortality. And looking at all this data together, WHO says, please give corticosteroids, specifically 6 mg of dexamethasone for all patients who are hypoxemic. Alternative is 50 mg hydrocortisone every 8th hour. Note that methylprednisolone is not there in this recommendation, and the duration of therapy is only 7 to 10 days. Don't give it for patients who don't have severe disease. Tocilizumab, again, a drug that has been turned around on its head. This is an IL-6 inhibitor, a lot of experience with autoimmune diseases, specifically for this cytokine storm. Now, the cytokine storm term is quite popular, but people have actually asked, is there cytokine storm in COVID? Apparently, the levels in straightforward ARDS, non-COVID ARDS are far higher. Similarly, the levels are higher in sepsis. And certainly, there's no role for measuring your IL-6 levels. This test became very popular, but there's really no connection between that level and a requirement for tocilizumab. And obviously, the levels go up after giving the drug. So don't remeasure. This is a study which showed that levels of IL-6 are actually higher in patients with regular conditions, sepsis with ARDS compared to COVID. So what is the rationale behind tocilizumab? The rationale was that virtually every single retrospective study suggested that it works. This is a huge multi-center US cohort study, clear mortality benefit. It was criticized because of its retrospective nature, but when they put everything together, the number needed to treat was 11. So suggestions that tocilizumab was worth using. And then the RCTs in less seriously ill patients came out. This was a JAMA study, showed no benefit. This was a French study, again, no significant benefit. This is another JAMA study showing no significant benefit. So certainly in mild patients, it didn't seem to work, right? So this was another study in the New England. All these studies saying that if you gave it to patients who were not very seriously ill, it didn't seem to work. Luckily, none of these studies had more infections as a side effects, which was what the retrospective studies had shown. And this is to compare that the number of patients who were seriously ill were far higher in these retrospective studies compared to these prospective studies. Then people started looking at tocilizumab in more seriously ill patients. This was the first trial, Covacta. This was a global multi-center trial. This was a negative trial. No significant difference in clinical status on the ordinal scale or those not mechanically ventilated. So is that the end of tocilizumab? Then came the Impacta trial, once again a negative trial. However, by this time, the standard of treatment was improving. Note that in these two trials, certainly in the Covacta trial, very few patients got corticosteroids. So perhaps corticosteroids are the key to making tocilizumab work. And finally came a positive trial, which showed that tocilizumab and sarilumab, these were pooled IL-6 receptor antagonists, had a lower mortality compared to standard of care. This was the REMAP-CAP trial. For the first time, tocilizumab came back into vogue. However, in REMAP-CAP, they had stringent criteria as to when to give it. You have to give it early. And you have to give it only if your O2 requirement is greater than 0.4 or you're requiring more levels or higher levels of respiratory support or vasopressor support. And you have to give it early. If you waited 48, 72 hours after getting worse or getting tubed, then there's no role for this drug. You have to give them within 24 hours of standard of care, including steroids, is the outer limit for tocilizumab to work as per REMAP-CAP. And this showed that if you follow this particular protocol, you had a mortality benefit. Finally, recovery once again came to the rescue. This is yet to be published, but the preprint on tocilizumab for recovery had one more inclusion criteria, CRP more than 75. This study did not have stringent within 24 hours inclusion criteria, but it again showed a reduction in mortality. Obviously, numbers are huge here. Certainly the biggest data that we have, subject to this being retained when it's published. Time to discharge alive, again, a benefit with tocilizumab, and putting it all together, a benefit with tocilizumab. So these were the key findings in recovery. Probably the most important is here. Patients receiving corticosteroids, 28-day mortality was 27 versus 33. So good numbers to counsel patients. If you get steroids, a 33% chance of death. If you get toci, that falls by 6% or so. So this is where we stand on tocilizumab. Retrospective studies showed benefit, doesn't work for less seriously ill patients, helps for more seriously ill patients, provided you start it within 24 hours of hospitalization or requiring steroids. Now, this is itolizumab. This is like saying that if your last name is Kapoor, you got a job immediately in Bollywood. So this last name was Mab, so it got a job immediately for COVID. Well, this is the most recent study. This was published very, very recently. I came across it today, actually, for itolizumab, a study published from multiple government hospitals, but industry sponsored by the maker of this drug. Eligibility, somewhat hypoxemic or high baseline markers. So you could just get into the study if you had high baseline markers. Not many patients. Finally, they had 22 who got itolizumab, 10 given standard of care. And you can see that there is some improvement in oxygenation, some improvement, very small study, 20 versus 10. So for whatever it's worth, it seemed to work well, no data on safety, etc. So we really need a proper RCT and no safety data. So don't use till better data emerges. Certainly don't use just because it sounds similar to tocilizumab. A word on this drug called baricitinib. This is not readily available in India. It's been used for rheumatoid arthritis. This is the study on baricitinib, but this did not include corticosteroids. So it's not really very useful for patients currently, but there was some benefit. So if you have a rare patient whom you can't give dexamethasone or contraindicated, then baricitinib can be used in combination with remdesivir. That is the take home from the baricitinib study. What about colchicine? Easy to use. It's being used a whole lot for coronary artery disease right now. And this is the COL Corona trial, which is yet to be published. which looked at very early patients. You got to start this drug within 24 hours of diagnosis and have one of these risk factors and take it up to 27 days. If you did that very, very early, although the trial was terminated early, perhaps you had some benefit. So you need to treat a lot of patients very early to get some benefit. So really can't accept that this is a drug we need to give all patients with COVID. We really need more evidence. So among these immunomodulators, corticosteroids will work just fine. I just came across a study on inhaled corticosteroids with budesonide. I haven't put that in, it's still too preliminary. Tocilizumab will work fine if you give it very early. Similarly, sarilumab, which is not readily available in India. No role for vitamins. We could go on ad nauseum for vitamin C, vitamin D, etc. None of these really work. So really nothing works. A lot of things have struck out. At least that part of it is clear. But what is left is not particularly good. Just a word on anticoagulation. We all give prophylactic anticoagulation, which seems to be as good as therapeutic anticoagulation. One thing we have learned in COVID is that the rates of bleeding are almost the same as the rates for clotting. So be careful about therapeutic anticoagulation. You might precipitate a bleed. And several trials have actually been stopped because of a futility and perhaps lack of safety. And so current guidelines suggest that just give the standard thromboprophylaxis to all these patients. Do not give them high dose heparin or therapeutic anticoagulation unless there is a documented indication. A final word on chemoprophylaxis. This was the Indian trial published by ICMR in their own journal, which suggested everybody should be on hydroxychloroquine. Was not replicated when done abroad. Again, a cluster randomized trial did not help after exposure. And WHO says that there is no recommendation at all recommended against hydroxychloroquine. I can't think of a single healthcare worker who's taking hydroxychloroquine during the second wave. So this is our Apollo Hospital protocol for COVID. On the left in green are mild patients who are not hypoxemic. We don't give them anything. We just monitor them closely, paracetamol. The moderately ill patients would always get dexamethasone and DVT prophylaxis. If they come in early and they have low O2 requirements, we would say consider remdesivir. The severely ill patients in the ICU would always get DEXA, prophylactic anticoagulation, and we have upgraded tocilizumab based upon recent data, but you have to give it within 24 hours of worsening. We rarely use antibiotics for COVID. So this is my last slide. What's in? Dexamethasone, absolutely. That is the drug of choice for COVID. That hasn't changed in the last 6 to 9 months. Prophylactic anticoagulation rather than therapeutic anticoagulation. Remdesivir if they come in very early and they have mild disease. Tocilizumab if you started early and you're severely ill. Lots of stuff is out, and I don't expect this will change a whole lot in the near future. That's my last slide. Thank you very much. I will conclude here and stop sharing. Over to you, Dr. Nambi.
Yeah. Thank you, Dr. Ram Gopal Krishnan. Now I understand I've given you a huge topic. Probably I wanted to finish you within 20 minutes. I don't think it's possible. But I think you've gone through the entire thing with the role of antivirals, the anti-inflammatories and anticoagulation also. A lot of questions with respect to therapy. Probably I think most of it could be accommodated into the panel discussion session. But there is one question on the red cell distribution with RDW as a marker of COVID prognostic marker. I know that you have a publication on that particular thing, RDW. Would you like to share your thoughts on RDW in patients with COVID?
Yeah, the red cell distribution width of more than 14.5 suggests a worse prognosis, and it's a marker just like CRP or D-dimer or any other COVID biomarker. It's just that it's readily available. Every time you do a CBC, the lab will automatically give you that information. It's just like any other biomarker for severity.
Ivermectin, I believe in the latest AIMS protocol, still it insists on using ivermectin for 3 to 5 days. In your lecture, you had pointed out that probably you would not consider it use. There were many people who pointed out that AIMS protocol does include ivermectin in the treatment. I understand that the evidence base for that is not so strong and it is evolving. And any role for combination drugs like plasma plus remdesivir in the initial 7 days of illness, I think that looks a little far-fetched, but what is your thought process on that?
Regarding ivermectin, Dr. Tanu certainly didn't mention any filarial worm mutation that COVID has taken. So I don't see how they've recommended ivermectin. It's not evidence-based. Regarding combination therapy, yes, if somebody comes in early, plasma will work. Remdesivir probably will work. The problem is both are parenteral therapies and they have to be given very early. So, you know, with the second wave, so many patients, how do we pick and choose? Obviously, we have to pick and choose more seriously ill or hypoxemic. The vast majority of mild cases will get better on their own.
Yeah, I think the remaining questions, we have a large number of questions to be answered that we could probably take during the panel discussion. Probably, Dr. Ajik, if you have some time, probably you could go through those questions.
I'll answer them on the chat box.
And then probably you can answer it in the chat box. Thank you.
Sure.
Thanks once again, Dr. Ramgopal Krishnan. And then we will move on to the next lecture. The next lecture will be on COVID vaccine. Know that we do not know whether it is Covaxin or Covishield. And for that, we have Dr. V. Ramasubramanian, who is a senior consultant in infectious diseases at Apollo Hospitals, Greaves Road, Chennai. And he is one of those pioneers in the field of adult vaccines in India. As far as I know, probably he was the first one who had started an adult vaccine clinic in India probably 15 years ago, when no one would have even thought about adult vaccines. I don't think there is anyone else who's better to talk about vaccines. And then he is the Clinical Infectious Disease Society Vaccine Committee chairperson too. And he's my guru. Off to Dr. Ram Subramaniam, please.
Thank you very much, Dr. Nambi. I hope you can see my slides and also hear me well.
Yeah, please go ahead, sir.
This is a post which I came across. I think it has been going viral in the social media on how safe you are after vaccination, and it's similar to marriage, you know, somebody being wished for a happy married life. These are my disclosures. And this is something which we came across last time, that everybody wanted a vaccine. But when a vaccine came up, there was a lot of people clamoring that the vaccines may not be safe. You know, this is unfortunately hampered the process of improving your herd immunity. And it is like people saying, I don't want the vaccine because this bridge is only 99.997% safe. I think I will swim. Now, this is the current state of affairs with COVID. We can see, as Tanu said, people are dying in Mumbai, and in Chennai, it is just picking up. And people are still reluctant to take vaccine because they feel it may cause infertility or impotence and several factors. You read about something that, you know, in England, they have stopped the vaccine because of reasons of clotting, and you are worried about that. So I hope at the end of this talk, in the next 20 minutes or so, we can have a better clarity. Now, there are 4 types of vaccines we all know. There are 2 where we give the antigen, which is directly injected into the host. We have the whole virus vaccine, which is basically injecting a weakened or inactivated COVID virus. The example for this is Covaxin. And we don't have the protein subunit, but the protein subunit basically uses a part of the viral antigen, which is directly injected. This is cheap and easy to do. This is not yet licensed anywhere in the world. The only problem is it may induce a very weak immune response. So you need to add a lot of adjuvants to this to ensure that the immune system response is better. We, of course, have 2 other mechanisms of giving the vaccine and inducing immunity. One, which is done in India, the Oxford vaccine, or the Covishield, where you take the chimpanzee adenovirus non-replicating virus and you add a bit of the genetic element which will code for a spike antigen and inject it so that it stimulates the body to produce the antigen and thereby also respond with antibody production. And lastly, the Moderna and the Pfizer vaccines, which are mRNA vaccines, the first time such kind of vaccine technology has been used, whereby you ensure that by giving directly a synthetic version of an mRNA, it stimulates and produces the antigen, and thereby the body responds to it. These are all the various examples of the various companies, the efficacy, the storage, the number of doses which are available. Among these, you have the Moderna, which is the mRNA vaccine, and the Pfizer vaccine. The CIDS Cadila, which is from India, is still in phase 3 studies. The AstraZeneca vaccine is available, and the Johnson & Johnson vaccine is also licensed in the United States. You'll find that the main problem is with the storage of the mRNA vaccines, whereas the other vaccines, and especially the DNA vaccines, which will come in hopefully in the next few months, can be stored in the room temperature also. Of course, the other vaccines, which are, some of them are available, the Chinese vaccines are available in the Middle East also. Bharat Biotech Covaxin also shows a response of 81%. You look at this, that the highest efficacy is from the Moderna and the Pfizer vaccines, close to 95%. The Sputnik vaccine is about 90%, the AstraZeneca about 70%, Johnson & Johnson, which is only a single dose, about 66%, and we have the Bharat Biotech initial studies have shown that almost 81% efficacy. When I say efficacy, the chances of preventing a symptomatic COVID infection is, as I said, 95% for the Moderna and the Pfizer vaccines. But we also know that the chances of preventing hospitalization, death, and severe disease is almost 100%. So the bottom line is vaccines are our best chance for keeping ourselves safe at this point, unless we start seeing more and more variants. These are all the other Indian vaccines which are in the landscape. They are still in the process of development, and we will know Aurobindo is coming out with a vesicular vaccine platform. We have Biologically coming up with a recombinant protein antigen base. So several are in the pipeline, but at present in India, only 2 vaccines are available. So I'm going to limit my talk mainly to Covishield and Covaxin. You'll see that India stands somewhere here about 10 million doses when you compare to Israel, which has already inoculated more than 100 million doses, and we have a long way to go. And the idea of doing this is to ensure herd immunity is built up. Now, this herd immunity, which is an elusive concept, I hope this figure can explain that. If you have an infected person who's the index case, he can transmit it to several people in the population who are susceptible. Okay, so these blue people can also get infections from these infected red men. Whereas if people are protected and already are immune, the green men you see here, the chances of an index case infecting these is blocked, and you can infect only one person who subsequently cannot reach other people because he's not coming into direct contact with them. So if about 75 to 80% of the population have immunity, then the chances of disease transmission is minimized. But we have to understand that herd immunity as a concept is applicable only to a population and not an individual in the population. And it is not a magic cloak that can be carried everywhere. So if Chennai has a herd immunity of 80%, I once move out of Chennai to go to Delhi, I may not be protected in Delhi because the herd immunity may be much lower there. So this has to be kept in mind. The second point we need to also understand is the efficacy of a vaccine versus the effectiveness. Efficacy is the degree to which a vaccine prevents disease and possibly also transmission under ideal and controlled circumstances. That is basically under study conditions where you compare a vaccinated group to a placebo group. Whereas effectiveness refers to how well it performs in the real world. There are several factors like the medication people are taking, the underlying chronic illnesses, the age of the patient, how the vaccine is stored and administered, and several everyday conditions which can reduce the effectiveness of the vaccine at preventing the disease. So if you look at how the studies were done, they basically took 2 populations which were reasonably matched with regard to age and other factors. One group got the vaccine and the other group got the placebo. To eliminate any unintentional bias, neither group knew whether they received the vaccine or placebo, and they carried on in the normal fashion they would do. And they were exposed to hopefully a similar kind of scenario. And the studies showed, for example, in the vaccinated group, 8 persons fell sick from COVID and 1 was severely ill. Whereas in the non-vaccinated group, 162 people fell ill, out of which 9 were severely ill. So based on this, for example, the Pfizer vaccine, they concluded that the protectiveness was about 95%. But what does it really mean? Does it mean that if you have a population of 100,000 and who have the vaccine, 5,000 people only will be infected? No, that is the current scenario. If you have 100,000 people, almost 5,000 people are getting infected. What it means is if, for example, in 100,000 people population, 1,000 of the population become sick if they don't get a vaccine. If you give the vaccine, only 50 of them will get sick. So the number of cases will be only 50, which means the risk reduction in the whole 100,000 is almost 99.95. So this is how you interpret the efficacy of the vaccine. And if you compare the various vaccines and say how effective the vaccine is, you'll find that the Moderna and Pfizer are right here on top. AstraZeneca, the Covishield is somewhere here. And how often did somebody have a systemic vaccine reaction? It was more often seen in Pfizer than with this in general. You can compare that with pneumococcal and flu, where the effectiveness is much lower, somewhere in the region of 40% only, or 35% in some situations, sorry, 60% with flu and 70% with pneumococcal vaccine. If you divide it by group, you'll also find that there is a disparity. But as I said, all the vaccines are effective in preventing death, in preventing hospitalization and serious infections or severity of the disease. And it also gives you reasonable protection against getting a significant infection. What about the vaccines and the variants? Studies available from Covishield and Covaxin tell us that the Covishield has a high efficacy against the British variant, but very poor efficacy against the South African variant, only 25%. It is also effective against the Brazilian variant. And early studies, we still have studies going on, too difficult to say. It is like the difference between experience and experiments. Right now, we only have some experiments. We need the experience to say that Covaxin is also effective against. We know that through studies, experiments, that it is effective against UK and Brazilian variants, but studies are still on to see whether it will help other variants also. But please remember, whatever the variants, at present, the vaccines, even though may not be fantastic, they give some form of protection. So it is definitely better to take the vaccines. Who should not be given the vaccines? Covishield, only people who have had a previous allergy to the vaccine should not be given a vaccine. Otherwise, everybody can get it. In the initial pamphlet of Covaxin, all these were indicated as contraindications: immunocompromised, people with bleeding disorder, people on blood thinners, pregnant, breastfeeding, and people with serious health injuries issues. But the latest pamphlet says only people with a history of allergies to the vaccine or the earlier allergy to vaccines, or people with a fever should be, vaccine should be avoided in these two. Otherwise, it is almost similar to those who can be given Covishield. So if you need to know what you're allergic to so that you can avoid the vaccine, Covishield contains L-histidine hydrochloride monohydrate, magnesium chloride, hexahydrate, and most importantly, polysorbate 80, which is believed to be the agent which causes allergy in a lot of people. This is similar to the polyethylene glycol 2000, which is seen in the Pfizer vaccine, which induced anaphylaxis. Covaxin contains these, but I think it is very difficult for us to know which agent we may be allergic to. What about the side effects? Very common side effects include local side effects of warmth, redness, swelling, and bruising, may feel unwell, tired, feverish feeling, nausea, and also muscle pains. Common, which may affect 1 in 10 people, is maybe a lump at the injection site, fever, flu-like symptoms, and uncommon symptoms may include dizziness, anorexia, abdominal pain, excessive sweating, and also lymphadenopathy. The side effects for Covaxin are reasonably similar to this, but anybody experiencing side effects more than 48 hours after taking the vaccine should reach out to a medical personnel to see whether they have actually got COVID, because we are seeing a number of cases right now where they take the first dose of vaccine and promptly come down a week later with COVID. And remember, there is no evidence that COVID-19 vaccines lead to infertility. What is more interesting is the recent deduction that people who receive the AstraZeneca or the Covishield vaccine can develop what is called VITT, vaccine-induced prothrombotic immune thrombocytopenia. This is believed to happen in 1 in 125,000 to 1 in a million who are vaccinated. Generally, less than 55 years, women more commonly, as cerebral sinus venous thrombosis or cortical sinus venous thrombosis occurs specifically between 4 and 20 days after vaccination. So there is thrombosis, which may affect other blood vessels also, and they also show thrombocytopenia. So anybody who presents with a persistent severe headache, focal neurological symptoms, seizures, blurred vision, shortness of breath, chest or abdominal pain, swelling and redness in a limb, pallor or coldness in a limb, all featuring thrombotic tendencies. And if the onset is between 4 and 20 days, and you see that there is thrombocytopenia, platelet count of less than 150, then you evaluate for the possibility of VIPIT. You look for an elevated D dimer, a normal blood film, and imaging to confirm a blood clot. If these are seen, then it confirms VITT, and you need to do investigations to look for the platelet 4 antibody, which is very similar to what we see in heparin-induced thrombocytopenia. It is typically seen, or should I say more commonly seen, in women, typically less than 30 years of age. And what has been shown is if you have had one dose and you're fine, you can go ahead with the second dose. This typically happens only with the first dose. Treatment, no heparin, no platelet transfusion. First-line anticoagulants like the directly oral anticoagulants, including rivaroxaban, apixaban, endoxaban can be given. Hematological opinion, and if it is a severe issue, IVIG is recommended 1 gram per kilogram for 2 days in severe life-threatening blood clots. So this is the situation, but the current EU has recommended that this can be, the Oxford vaccine can be given to anybody over the age of 30 years without any issues. If they are less than 30 years and if there is an alternative available, go for it. The benefits of the vaccine is any day better than the risk it induces. To give you an example, weighing the benefits and the harms, for people with low risk, it's still the number of ICU admissions prevented by the vaccination is 14, though the risk is not very high. The risk is higher in the younger population. If they have a medium risk, almost 40 cases can be prevented from ICU admissions, and high risk exposure, almost 130 cases, which tells us that this vaccine should be given for the benefit because the risk is very, very negligible. What about indications? Anybody over the age of 18 for all vaccines and over the age of 16 if you're using the Pfizer vaccine. The underlying presence of non-communicable diseases like diabetes, high blood pressure, obesity is not a contraindication, they can go ahead. Pregnancy and lactation, even though the vaccine is not licensed, there is increasing evidence to say that people who are pregnant are likely to develop more complications with COVID, and the vaccine should be discussed with them and offered to them if they are willing to take it, and similarly for lactation. Children have a remarkably low death rate, 1 in 50,000 compared to 7,500 per 50,000 among those above 85. So in children, studies are going on for the safety of the vaccines. We should know in a couple of months. And immunocompromised personnel, there is no contraindication because none of these are live vaccines. All these people can get it. So the only reason somebody cannot get is if they have allergy to an earlier vaccine. Aspirin and clopidogrel are not contraindication. You don't need to stop the dosing of these two drugs. Anticoagulation with warfarin, if the person has an INR of less than 3, they can go ahead with the vaccine without any other issues, without stopping the drug. If they are on other anticoagulants, including apixaban, rivaroxaban, or other agents, it is recommended that on the day of the vaccine, they defer taking the medicine till they finish the vaccination. In some people, the precaution they have advised, especially in people who are on anticoagulants, is to use a thinner gauge needle, 23G at least. Give it intramuscular. There is no recommendation on subcutaneous injection. Give it intramuscular, but press that area. Don't rub the area. Press the area for at least 3 to 5 minutes to prevent complications. What about, these are guidance from the American Society of Rheumatology on timing and vaccination for immunomodulatory therapies. Anybody who's on hydroxychloroquine, IVIG, or steroids less than 20 milligrams of prednisolone per day, no modification is necessary. They can take the vaccine along with the medicines. People on sulfasalazine, leflunomide, mycophenolate, azathioprine, cyclophosphamide, or if they are on a prednisolone of more than 20 milligrams per day for a month, still no modifications are necessary, but people who may be on these may have a less robust immune response. Methotrexate, who are on weekly treatment, hold the methotrexate 1 week after each vaccine dose for those with well-controlled disease. So these are the simple recommendations. Anything more, I think you need to speak with a rheumatologist. Other issues, timing of the vaccination, whenever it is available and you're eligible, please take the vaccine. The interval between doses, now it is very clear that 12-week interval between Covishield 2 doses actually gives a better immune response. The Indian government has made it now between 4 to 8 weeks to make it easier as a campaign process to get the vaccine. But for Covaxin, it remains 4 weeks. Post-infection, generally there is no specific recommendation. You may have antibodies up to 6 months, but anytime after 6 weeks or even 3 months, they can have the vaccination. If you develop an infection after the first dose, is it because of the vaccine? No. These are not live vaccines. There is no possibility. But if you develop an infection after the first dose, when do you time the second dose? There is no clear recommendation available in the literature, but it is believed that once their fever settles and if they are due for the second dose, they have recovered from the infection, you can go ahead with the second dose as per the original schedule. Is there a role for antibody screening pre and post vaccination? No. there has been no body which has recommended any screening of antibodies pre or post vaccination. So what has changed? What is new after the vaccination? If you've been fully vaccinated, you can gather indoors with fully vaccinated people without wearing a mask. You can gather indoors with unvaccinated people from one other household, for example, visiting relatives without masks, unless somebody has an increased risk of severe illness. And if you're around someone who has COVID-19, you need not stay away from work or from others or get tested. But if you are a healthcare worker, probably you may need to test, because even though the virus prevents symptomatic infection significantly, you may have asymptomatic infection. And if you're a healthcare worker, you may put your patients under risk. So it is possibly recommended that you screen yourself if you are living with somebody who develops COVID, and if you're vaccinated, and even if you don't have symptoms. What hasn't changed and still remains the same? You still need to use a mask and practice social distancing and avoiding poorly ventilated areas in public, gathering with unvaccinated people, visiting unvaccinated people who may develop infection from you if you are having asymptomatic disease. Avoid gatherings, avoid international or domestic travel unless they are essential, and watch out for symptoms of COVID. So there are a lot of difference in keeping ourselves safe, but we still can get disease, still can get the infection. Now, this is something which I wanted to convey to you, that there is a lot of infodemic or false information going on. What comes out in TV, 37 doctors of Gangaram Hospital test COVID positive, and all the 37 doctors were vaccinated, conveys a very, very inappropriate message to the public, where you know that the protectivity of vaccination is very high and significantly prevents hospitalization. So this is what we need to fight against. And lastly, remember that social distancing will never work in India. You know, we are people who are used to company, we are used to proximity, and we love being close to each other, and also physical proximity is what we like. So probably vaccination is the only way forward in India. I'm going to leave you there, and I'm open to questions.
Thank you, Dr. Ram Subramaniam, for your eloquent lecture on COVID vaccines. I think I would probably request you to be part of the panel discussion. Is it possible for you to be in? Why I'm saying that is Dr. Bharat Purandare was supposed to join. He has some connectivity issues. He may not be able to join. And in the panel discussion, probably the questions on vaccines, everything, probably we can ask if it is okay with you. Probably you can be a part of the panel discussion, or if not, we can take the questions on.
I can be for a little while. I may need to leave a little early, but I will stay on for as long as possible. If it is going to be till 8, I think I should be able to manage to stay on.
Sure, fine. Thank you. Then what we would do is probably start the panel discussion and then have the questions pertaining to the vaccines. With that, we could start the panel discussion. And I would request Dr. Kavita Saravu, who is the professor of infectious diseases at Kasturba Medical College Hospital, Manipal. And Kasturba Medical College, Manipal is recently accredited for DM and infectious diseases. So post-MD candidates could apply to their institute to join. And she's been one of those earliest members in our society. And she would be leading the panel. And the panel members would be Dr. Ram Subramaniam for thankfully accepting it in a very, 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 very short notice. And then we have Dr. Priscilla Rupali from Christian Medical College, Vellore, who is again a professor of infectious diseases there. And then we have Dr. Vishnu Rao from Apollo Hospitals, Hyderabad, who is an infectious disease consultant and trained with us at Apollo Hospitals, Chennai. And probably we would start with this, and we are running around 7-8 minutes late. Probably we can plan to finish around 8-10 p.m. And then we would leave Dr. Ram Subramaniam around 8 p.m. As per his wish, we would do that. Thank you. Off to Dr. Kavita.
Thank you, Nambi, for that introduction, and I'll be happy to moderate this session. I'll be sharing my screen now. Is my screen visible?
Yeah, it is visible. Yes. Please put it as a slideshow if we can do it.
Yeah.
Yeah, thank you. Please go ahead.
So we had interesting sessions so far on variants, drugs, and vaccines. So the whatever is remaining about COVID, we'll take up in this panel discussion. I welcome the panelists, Dr. Priscilla Rupali, Professor of Infectious Diseases from Christian Medical College, Vellore, Dr. Vishnu, Consultant, Department of Infectious Disease, Apollo Hospital, Hyderabad, and Dr. Ram Subramanian from Chennai. So we are in India, we are in the second wave, and we have had more than 1 crore cases of COVID-19 and more than 1.65 lakh deaths so far. And from the low of about 9,000 to 10,000 daily cases from November, we have February, and we have again gone past 1 lakh cases per day. And it's still increasing probably. So we are very much in the second wave. So my question to the panelists is, what may be the reason for COVID-19 second wave? So, Dr. Vishnu, would you like to take this question?
Yeah, yes, ma'am. So I think the reason for the second wave is number one. I mean, we started having opening of the schools and all the openings of mall, and a lot of people started coming out, and all those parties or the marriages which has been postponed. There is increase in the number of public gatherings. Number one, and number two, and also it's a pandemic fatigue. I mean, everybody. As the time passed on, the infection control, the infection control precautions also been has come down significantly, and whenever we go out, there are no masks. And the third one is the emergence of variants. So I think these three are the collective causes, like increasing gatherings and reduction in the infection control precautions and the emergence of variants. I think these three are the collective cause for the emergence of for the second wave. This is what I think.
Is there also a big number of vulnerable population? Because at one point of time, the cases had come down.
Yes, I mean, a majority of the cases, what we are seeing here are those people who have actually majority of the people who got who did not get infected during the first wave are actually the majority of the people what we are seeing in the during the second wave. Also, the number of reinfections are also increasing. So I feel that it is most of the, because all this population who did not got infected, they were adherent to the precautions, or their adherence to the precautions during the first day. But as the time passed on, the things get lighter, and people started, started taking things for granted, and reduction in the, infection control precautions. And that's what we are seeing here currently in this pandemic, at least in here in Hyderabad.
Yeah, thank you, Vishnu, for that. So definitely, as discussed, it's still overcrowding, and Dr. Ram Subramanian had shown it so very well that how difficult it is to maintain so physical distancing in India. And Dr. Tanu has covered a lot on variants as well, and it summarized very well the causes for second wave in India. So the question we have been hearing in the media is that the symptoms and severity of the disease, it is different in the second wave. So are we seeing it differently, or it is, if it is, how is it different? I'm sure that there is not much data which is very well documented, and it will need time, but as per the experience of the treating clinicians, what do you think about the characteristics of the second wave? Dr. Priscilla?
So, hi, thank you, Kavita, for the question. So the symptoms and severity of disease in the second wave seems to be slightly different. So we have an unusual time here in the sense that we have some population which is vaccinated versus those who have not been vaccinated. Now, younger people are actually being noticed to have disease. And we do notice that the severity of disease is noticeably seen in the younger population. I wonder if Tanu might comment on this, because I think Mumbai has seen the second wave and the third wave much earlier than actually Tamil Nadu has. So we are still kind of, on our surge right now. we don't have data yet with regard to our search, but whatever we've noticed so far seems to be that more and more younger patients are being involved here.
Is there a
Yes.
shift towards gastrointestinal symptoms? There were some.
So yes, you're quite right. A lot of patients who we have diagnosed COVID in have had very unusual symptoms. So we've had people who have fainted in theater, people who've had like sweating, people who had some diarrheas, and yes, this or just severe myalgia, which kind of prompted them to go ahead and get tested. And only when they were checking whether they had fever, they were found to have mild low-grade fever. So yes, the symptoms seem to be slightly different. Severity seems to have moved towards the younger population as compared to what it was in the last wave. I wonder if Tanu might want to comment if she's still on.
Yes, I'm
Tanu,
there.
if you're here, please.
Yeah. So I agree that we are seeing younger people, but one of the reasons is that many of the elderly people in Mumbai have received the vaccine because it started. So what we are seeing is that anybody who is 3 weeks after the first dose of the vaccine gets a mitigated illness. So that may also be the reason why we are seeing more younger people and children. It's definitely very apparent that children are getting severe disease, which they, not I would say severe, but moderate disease, which we never saw in the first wave. So there does seem to be a shift.
Also, the question on infectivity, do you think more of family members or more of the people with contact are really testing positive?
I definitely feel that the transmissibility seems to be high. And that's what's being noticed all over the countries. Whether it is because of a variant or not, it's difficult to determine at this moment. I think from Tanu's data, which she presented in Mumbai, it does seem like that variant might be more transmissible. But I must say, I have no experience about Tamil Nadu yet. We have not sequenced enough. So we won't know this at this point in time. But it seems to dictate that it is far more transmissible than it was previously. Yes.
In Hyderabad, we are seeing two different types of presentation, which we did not see in the first wave. One is as the younger population, and the presentation as acute undifferentiated febrile illness, like the fevers going as high as 103, 104 by day 5. In fact, we never used to give steroids till the first day, till day 7, until the onset of hypoxia. But we are seeing a subset of patients, especially in the younger population, who are coming with the temperatures of 104, 105 by day 5. And we are forced to admission because the patient looks so toxic. This is one thing what we are observing here, number one. And number two, the atypical pneumonia presentations. We are increasingly seeing cases which look like lobar pneumonia, or the infection starting in one lobe, then progressing to the other lobe in the same lung, then reaching the other lung. So these two types of, and the CT scans are not typical of COVID, what we used to see before. So these two are, we are increasingly seeing currently in this pandemic, especially in the younger age group, at least in Hyderabad here.
Dr. Ram Subramaniam, do you have any different thoughts on the second wave? I know that you have a different line of thinking, and probably you could voice your thoughts.
I was waiting for this. I was wondering how you are keeping quiet. No, it's just that at least in Chennai, what we have seen so far doesn't corroborate what is happening elsewhere. Maybe we are a little early in the course of the illness, but to me, so far what we have seen, the only difference I can see is in the earlier part of the first wave, we saw more people who were out there working, people who had to work, come down with the illness. There were a lot of younger people. And out of every one person who got tested, there were at least 10 to 15 people who did not get tested for various reasons. So the numbers were actually much, much higher, but we were picking only a few. Whereas in this second wave in Chennai, at least, because it is now involving more affluent people, people who started going to weddings, for travel, for meetings and dinners and parties, it is hitting them. These are more affluent people. So for out of every 10 persons who get tested, there are probably a couple more who may not get tested. I've seen people, and children are now coming out. Earlier, they were all protected. Now with the more people relaxing the norms, we find more children becoming, developing the infection, being tested. And so the testing and pickup is much higher this wave than the earlier wave. That is the reason. I still don't see severe illness in people yet. I cannot answer to the fact, yes, we do see a lot of, at least in the last few weeks, more people test negative. People with classic symptoms who are negative. I don't know the reason why. But with regard to the severity of the illness, so far I have not seen anything worse than the last time. Maybe it is yet to come to Chennai.
Thank you, sir.
Thank
We have heard and we have seen patients who are getting reinfected with who have had COVID for the first time. Do we have data from India about that, and how long the immunity lasts after COVID-19, and whether there's a difference in the disease severity when it is reinfection?
So I think we don't have data from India. I think that's what we have to acknowledge first and foremost. But it does seem that after having an active disease, we do find that it's less likely if you've had the disease before. This is just a preliminary analysis from what we found in our healthcare workers. We find that very few of them are getting reinfected. It's not like to say that we are not seeing it at all. We are seeing it, and we don't know what the reason is. We have sent those. We are hoping to send those samples for sequencing. The people who do get reinfected, at least in our experience, seem to be somebody who are kind of having mild infections. They don't really seem to be severely affected at this point in time. Now, I think this is a common question. So patients getting COVID after receiving vaccine, and this is a very emotionally charged question all the time, and we get a number of calls a day. What we have noticed is if you take the second dose and beyond the 2 weeks after the second dose, the number of people who get symptomatic infection seems to be remarkably lower. But people within 2 weeks after the second dose, or after the first dose, yes, we have seen people getting COVID-19. Now, what are the possible reasons? Actually, it's difficult to say. I think a lot of people have postulated, the vaccination centers are crowded. Maybe they're getting it at the vaccination center. It could be that. Could it be that, it may be a variant? There are various postulates and various hypotheses. So, but I think we also have to remember that the vaccine efficacy here is 70%. So you may have a mild infection even if you have received the vaccine. I think we know that in 100% of the cases, it does protect against symptomatic and severe disease. And we are noticing that as well. Very few people are actually getting severe disease. And the people who we've had admitted in our ICUs or who have had severe disease have actually been people who have not received their full quota of vaccinations. So that seems to be the trend at this point in time. I welcome other panelists' opinions as well.
Thank you, Priscilla. Sir Ram Subramaniam, sir, you want to add anything to this? Repeat infections after vaccination.
Called something as the Peltzman effect. The Peltzman effect is where I don't know what I just came across it in the social media, that you probably become a little, flippant in your protection. You take one dose and then you start going out. So whatever it is, yes, we see a lot of cases right now with people who had one dose of vaccine.
Yeah, thank you.
If I may add, I think the scenario last year was completely different. We were not really allowed to test. Testing was not that prevalent. So we're just testing a lot right now. And that may be the reason why we're detecting more cases. I think Dr. Ramsub also alluded to that as well.
Okay, thank you. So moving on to diagnostics, we'll come back to vaccines further. So we have RT-PCR and we have rapid antigen tests, and at some point for some very few patients, people might have used serology. And I have seen some, at least in the social media or in the papers, newspapers, that there are increasing cases where the RT-PCR is negative and it is picked up by CT scan. So is there anything of this sort which is observed in the current wave? That is the proportion of RT-PCR negativity increasing in patients suspected of COVID-19? And what is the role of CT scan?
See, at least, I mean, this is a, one of the, queries lot of the other colleagues are also discussing, where a lot of concerns has been raised about, increase in the number of cases which are clinically and radiologically COVID and the test coming negative. Though, first of all, we need to understand the fact that the test can be negative in 30% of the time. But however, other clinicians, they out of their personal experience are quoting that, say one person in the family is positive, the others are all symptomatic, others are coming negative. We did not see this kind of pattern before. So a lot of questions has been raised about, are we able, will the mutants be picked up by the current diagnostic test? So when I have a discussion with my microbiologist, I was told that the test can miss the variants if there is a mutation at the primer binding site. That is the time when the test can miss, it seems. But however, majority of the platforms, whatever we have, they are testing 2 genes. So even if one gene is missed, so other gene can be picked up. So that's what the information I got from my colleague, my microbiology colleague, and I was told that current diagnostic tests, their current standard is that they can still identify the mutants, but there are increasing reports that even the RDRP gene can be missed. So probably more data is required, and even the CDC says that certain kits can miss the variants. So I think more and more data is required. As of now, this is what is the current understanding on it. Yeah.
May I make a point here? Just one point from my experience, that the burden on the labs is very high here in Mumbai, because the number of testing has gone up, cases have gone up. So many times there is a high turnaround time, and we feel that somewhere the quality of the testing is also getting compromised because of this. The costs have come down to 600 rupees. So I don't know how much of primers or these are being used. So that could also be a factor. And second is that as far as the variants are concerned, they know that if there is a deletion between 69 and deletion 6970, which was seen in the UK variant, that was the one which led to missing on the PCR, but not the mutants which have been detected in our country. They don't seem to impact the diagnostic tests.
Yeah, thank you, Tanu, for that question. So the point is, when should we ask for CT scan? Just like in the first wave, or is there anything change what we need to have? Or can Dr. Ram Subramanian summarize what is the indication for CT scan?
No, I don't think much has changed since the first. At least we have to, I always, my colleague Ram Gopalakrishnan keeps saying that you start something which is a little iffy, you're starting putting your foot on the slippery slope. It's like saying giving dexamethasone to somebody who is an outpatient. You start giving steroids as an outpatient, that's the first step, and then it becomes much easier to do the same thing again. So on similar lines, now it has become a fashion that everybody who has a COVID test positive immediately gets a CT scan done. And I'm very sad to say that the public health also in Chennai, they encourage that if you have had a test done to ensure home isolation, they're asking for a CT scan. Now, this is ridiculous. I don't think CT should be done routinely in all cases. I think the indications for CT is if your 1 or 2 tests are negative and you strongly suspect it, get a CT done. If the person is clinically deteriorating, you get a CT done. If, for example, the person has been on steroids and you are not sure after 10th day he's still hypoxic, whether he may still have inflammation, you are looking at options, get a CT done. If you're thinking of a pulmonary embolism, get a CT with the pulmonary angiogram PTP protocol done. But on similar lines, I think we should have some basic guidelines on how to do it. Everybody is desperate right now for some sort of treatment, some sort of intervention. I think as doctors, we should ensure that we stick to guidelines and ethics. It's very difficult in times of crisis, but I think I very strongly believe you should hold your foot.
Thank you for bringing out that point. Thank you very much. So we have Dr. Ram Subramanian has given a fantastic lecture on vaccine, and we have these 2 vaccines, Covaxin and Covishield, approved from January. And also they have efficacy about 70 to 80%. And I think these points are all discussed, the interval between 2 doses. But there has been change in the messaging about the interval dose about between the 2 doses. So can you highlight on this issue?
No, I think it's been very clearly shown that for Covishield, you can wait up to 12 weeks. The response is better in 12 weeks, and the response from the first dose does not decline for up to 90 days. So up to 90 days, you're protected by the first dose. And when you give the second dose at 90 days, the immune response is much better. But for logistic reasons, I think the mass vaccination program in India, they have increased the dose from 4 weeks, but may have made it only 8 weeks. Because the longer the interval, it is more difficult, or it is more likely that people will not take the second dose. So you have to have a via media. That is why I think the government has gone for it. But it's very clear that up to 12 weeks gap can be given. The other worry is, if you take the vaccine in 4 weeks and then wait till 12 weeks and you are not able to get the second dose for various reasons, we are having a vaccine shortage now, then you will have very little time to catch up. So probably 8 to 12 weeks would be much better, though the government has said 4 to 8 weeks. With Covaxin, the interval remains the same.
To just add to that, the new Covishield AstraZeneca trial in the US, which showed 80% efficacy, the interval between the 2 doses was 4 weeks. So I know many people are disappointed that we took the second dose after 4 weeks and now the recommendation has changed. So they needn't worry, because that trial showed that it was good even after 4 weeks interval.
I took it in 4 weeks. So
is there any difference between Covishield and Covaxin?
So far, with available evidence, I don't think we can choose one over the other. The benefits of both are reasonably good. The safety is very good. So I wouldn't encourage anybody to go for one over the other at this point with the available evidence.
So one more question on this. If a person after first dose of vaccine gets COVID infection, then when should he get the second dose of the vaccine?
I was also very desperately looking for some guidelines, because we have a lot of patients, some of whom have had Covaxin, some of whom had Covishield. And the CDC says that, and CDC, says only about the Pfizer vaccines. The vaccine, once their fever settles and they are removed from isolation and they are stable, they can go ahead with the vaccine. So I presume that the second dose can be given as per schedule if they have recovered within the time for the second dose. I was not able to find any other information than this. If anybody else can help, I would be happy.
Does anybody else have any other opinion?
Yes, I feel we should follow the same principle which we do for vaccination with the first dose after a previous infection, that we should wait for at least 1 to 3 months.
Is there any evidence, Tanu? Have you come across any?
No, there is no evidence for that, but we are applying the same principle, because if somebody gets an infection and then we say you should take the vaccine after complete recovery. So I think it's just applying that same principle here, because the concern is for giving it early, whether you are going to in some way also precipitate some kind of inflammatory syndrome. And it has been seen that people who have taken the vaccine, who are previously infected, some of them have more adverse effects with the vaccination. Maybe
so, Tanu, I'm trying to make sure that everyone has understood. Did you mention 4 to 6 weeks after recovery?
4 to 12 weeks, yes. But at least 4 weeks, because again, the concern is that what if there's a shortage and they can't get it after 12 weeks, so that same principle. 4 weeks after the infection, recovery from the infection.
And also, if people have received convalescent plasma in their illness for COVID-19, what is the recommendation by the government?
That's 90 days, Kavita. So if you've been given convalescent plasma or monoclonal antibodies, I think you have to wait for 90 days before you give them the second dose of the vaccine.
Thank you. Let's move on. I think if there is somebody who has joined late and they have missed Tanu's presentation on variants, which in fact was one of the best presentation of a very complex topic, maybe we can just revisit that question, that whether our Covishield and Covaxin is able to prevent the infection against the variants. How effective is the vaccine against these variants? Tanu, would you mind answering this once again?
So basically, we are talking only about Covishield and Covaxin here. So it seems for Covishield, it works very well against the UK variant, because there is no drop in efficacy in the UK with using Covishield, and it has prevented hospitalizations and deaths. For Covaxin, we don't have in vivo data, but we know lab data that it neutralizes the UK variant. And as far as the South Africa and Brazilian variants, we know that there is hardly any protection offered by Covishield for the South African variant. And the only thing which I would like to say is that, the number of people who were, in the trial for the South African trial with Covishield, and the amount of severe illness was not enough to come to the conclusion whether severe illness can be prevented by the Covishield vaccine, even if it is the South African variant. And there is a feeling that it may still protect, because that figure of 25% was efficacy against any disease.
Okay, fine. So what about Covaxin?
Covaxin, there is hardly any in vivo data is not there because it has not been tested in any other part of the world. And in fact, so we don't have any data about Covaxin.
But there was a statement.
If you look at the, sorry.
There was a statement saying that it is 81% efficacy, Covaxin.
But that is for that in the trial of 25,000 people in India, where,
Yes.
We don't have any major variants circulating. So that was irrespective of the variants. However, there have been studies which have looked at the antibody levels which are obtained with Covishield and antibody levels with Covaxin. And what they have found is that they are almost similar, or in fact, Covaxin antibody levels are even better. And most people believe that the protection against variants is a function of how many antibodies you have. Because if you have very high antibodies, then the protection becomes good. And that's why Pfizer and Moderna work partly against the variants, because the antibodies induced by them are very high. So by that same analogy, we can say that Covaxin should also protect against severe disease the same way that Covishield does.
I think there was a small in vitro study which looked at the Covaxin, ex vivo study to check the plaque reduction utilization test for Covaxin. I don't exactly know how many samples were tested.
No, so I said it works for the UK variant. The lab study shows, but we don't have data about the South African variant.
Correct. That is true. I agree. So the vaccine, what is the knowledge on vaccine preventing infection, even the mild infection or asymptomatic infection, and transmission, ongoing transmission?
So Kavita, we do have data for the mRNA vaccine saying that it possibly does protect against asymptomatic infections as well, but we don't really have a percentage per se. We do know it's 100% protective against severe disease, and it probably does prevent even asymptomatic infections, but nobody's willing to commit to a particular number per se. I wonder if Dr. Ramsub has anything to say about that.
No. See, we are looking, I feel, too much into these numbers and trying to interpret them. We know very clearly the vaccines are safe and they prevent serious illness, whatever vaccine has been tried. So nitpicking between, 94 and 95 or 81 and 90, to me seems a little irrelevant at a time when less than, 10 million or 15 million doses have been given in India. So I think we have a long way to go. The only advice would be just take the vaccine as soon as you can. That's the only advice.
So there is data about Covishield in the study which was done in the UK. There was a subset of patients where they swabbed weekly and they found that it did not give any protection against asymptomatic infection.
Yeah, it was about 20% protection.
Yeah, but it
was not much.
It was not statistically significant because it overlapped 0. Yeah.
Okay, thank you. So Dr. Ramsubramanian had discussed about the herd immunity and the whole logic why we are trying to move ahead and ramp up vaccination to achieve herd immunity. But for measles, we know about 95% is the threshold for herd immunity, and for polio, it's about 80%. And we do not know probably exactly for SARS-CoV what should be the threshold to achieve the herd immunity. What India has still not been able to vaccinate a very large number. We have vaccinated about 10 crore individuals. And after initial prioritization of the priority groups, then it is time to engage the public and also ramp up the vaccination. So what strategy the government should do to increase the vaccine coverage? As of now, we have in India, we have about 6% of people who have received one dose of vaccine, and fully vaccinated is about less than 1% of population. So how do we achieve a wider coverage of vaccination? And there has been a question from the participant, what should be the vaccination strategy?
Vishnu, I
Vishnu.
want you to take this up.
Sir, I can take vaccine hesitancy, what can be done, but what can the government should do to increase the vaccine coverage? I don't think I'm an expert in that. I mean, you are the better expert.
No. I just want your opinion. I'm asking you because
sir,
it shouldn't be, influenced by the current situation. As an ideal
Yes, sir.
situation, what do you think, for example, in Telangana, you would suggest? I think that's what matters.
Yes, sir. One of the what I feel is one of the concerns a lot of people have is about the over projection of the side effects. Especially a lot of people are projecting on the side effects, which is very, very minimal. And there's lot has been circulated in the social media about the so-called thrombotic tendencies. And if we see, I think we should come up with the facts, come up with the numbers, so that it will give confidence for the people to take the vaccine. So that's what I'll try to do. I'll try to educate in mass. Educate them so that the hesitancy will come down. For example, recently the EMA has said that the likelihood of somebody getting thrombotic complications is 1 in 1 million doses, and British says that it is 1 in 250,000 patients. So it is very, very, very minimal compared to the amount of benefit is going to offer. So I try to concentrate on educating people in mass about the benefits of the vaccine, and trying to say that all the what are the vaccines we are giving safe, and how many lives it going to save, and how it is going to protect. So I think this is what I would emphasize to reduce the vaccine hesitancy.
I think it's a very valid point, because I'll tell you my personal experience. When the Covishield vaccine came in and when Covaxin came in, everybody was very skeptical about Covaxin, and everybody was going for Covishield at that time. So Covaxin wasn't even considered as a vaccine. But when this EU side effect issue came up, every patient, I have a clinic, vaccine center in my clinic, everybody wanted only a Covaxin, and the government wouldn't give us Covaxin. They were giving only Covishield, and we had a very tough time convincing people that both were equally good. The public just wouldn't take Covishield. They only wanted Covaxin, even though just a month before, nobody, thought high of Covaxin. So I agree with you. I think more important to focus on the safety of the vaccine and the necessity to take the vaccine than bother about side effects. I think that's very well said.
Sir, also there's a question on what about J&J vaccine? Can we approve J&J vaccine, a single dose vaccine?
I think studies are on now, and very soon we'll have more than a choice. And as we saw, this Covishield issue is typically in young women less than 30. So we are still way, behind coming to vaccinating less than 30-year-olds. So as of it is available now, go. And in the event that in future we get more vaccines like J&J, we can use that as an option for others who may be skeptical or who may have a higher risk of developing complications, even for variants for that matter.
So how can we make this vaccination as a public health intervention and agenda, more than just giving it in the hospitals to increase the coverage, to achieve faster and wider coverage? It is very difficult if you just limit to the hospitals.
I think at this point, we are still having shortage of vaccines. There are a lot of criticisms against the government saying, why should we give the vaccines out of the country when we need them? We have seen in the papers that several states are having issues with the vaccine availability. So at this time, I don't think we are yet ready to roll out all over India. But once the situation improves with regard to availability, I think that will be the next step.
And also the approval for all adults or even less than 45 years of age.
The same. I think once the availability is made, cleanly available for everybody, I think they are waiting for that. Probably that's the reason. But I think there is, everybody needs a vaccine, period, irrespective of age.
The vaccine hesitancy here in Maharashtra has gone away after the wave. It was there before, but now, everybody is seeing how they can get hold of the vaccine. So no discussion about side effects, nothing.
Does anybody have figure of what is the percentage of vaccine uptake in healthcare workers?
Actually, I can tell you in our hospital, it's about 85% actually. So, but I don't know what it is in.
That's good.
Other
Nambi, what do you think?
I think in Chennai, I think every Apollo hospital has a different one. There is the highest is 90% in one hospital. In Apollo Greaves Road, it is around 65%. It's a large hospital, so there are multiple thought processes. Another burning question that comes with vaccines is, should we check the antibodies? So there are many people who ask me, okay, they take 2 doses of vaccine. My antibody is 0, 1, 15, 20. So should I now take Covaxin? So what does this elite group think? Should we do antibody testing to check the fact whether the vaccine has worked in that particular person? There is no recognized body in the whole world which recommends to do vaccine antibody testing, but that's a common practice right now, especially among doctors. We don't recommend it to patients, but doctors do it, and then they look into those levels and then keep comparing. So what does this elite panel think about that?
The simple answer is no. I will leave it to the others.
Tanu, please unmute yourself.
Yeah, so I just wanted to add one thing that, in Mumbai, there have been these labs which are offering neutralizing antibodies to the spike protein, which is different from the other tests which were available. And all people are positive, whoever asked for it, but we've had healthcare workers who are positive, COVID, RT-PCR positive, and when you do their antibody levels, they are also positive. So that means there's really no, so you may not have antibodies and yet be protected because they're either not detectable or the T cells are working, or you may have antibodies and still get infected. And the other thing is that there's no serologic correlate of protection for COVID-19, unlike hepatitis B or something. So you cannot say that if your level is this, you are protected. That protection level is not there. So that is why it should never be done, because it only causes anxiety. People who do their antibodies think they are protected and they will not use precautions. And people who are not having antibodies will lose sleep and will try and see how they can take another vaccine, and they cannot take another vaccine because the app will not allow it. Somebody is asked in the chat, can they go and take Covaxin? How will they take Covaxin? It's all Aadhaar card based. You can't take more than 2 vaccines.
Thank you. Thank you. So there has been a question on requirement or the recommendation on pirfenidone for post-COVID-19, long COVID-19 or against fibrosis. Priscilla.
So I must say, I have no experience with pirfenidone as an antifibrotic agent in COVID. And I don't think there is enough data for us to routinely recommend it, which is the kind of patient where it needs to be recommended. I would actually leave it to the pulmonologist to decide. Do we have evidence to say that everybody with any kind of pneumonia in COVID should be given pirfenidone? No, I don't think there is evidence at this point in time. I think I would like to leave it with that.
There's a question on how long this brain fog in COVID-19 can last.
Okay.
Sorry?
Brain fog. So brain fog is a common term that has been bandied around. I think it was especially after the first wave in the US and UK. And it was thought to be kind of something that was seen as part of a long COVID syndrome. Most people believe that it lasts for about 3 months. But really, is there such an entity as brain fog? I think strict definitions need to be made, because my brain fog is not the same as somebody else's definition of brain fog. So I think this is most often used as a joke now, that we need to be very clear as to what is the definition. Is there any neurocognitive decline? Is there an encephalitis, meningitis? That kind of a thing has to be taken into consideration. So there's no clear-cut definition at this point in time. So I would say we don't know. That's a simple answer at this point in time.
Moving on to the one question, there was a question on healthcare workers' exposure and quarantine. Priscilla, can you answer that question? With the significant exposure, should the healthcare worker be quarantined if they have had vaccine?
Okay, so I think this is a common question that is actually asked. And I think just today also we were kind of discussing regarding this. If a healthcare worker has been exposed or has had a significant exposure 2 weeks after he's completed his 7 dose of vaccination, I don't believe he needs quarantine. I do believe that he needs to continue using, protective measures, mask, social distancing, and everything needs to be continued to be done, both at home as well as at the workplace. So if he's had a significant exposure, one thing that is, we don't have data regarding this, and we are not going to have data very soon. What has been recommended, I know the CDC recommends that, you can take off your mask and go here and there, but I'm not sure I'm comfortable with that at this point in time. We have 70% efficacy only, 30% of the times we may not. So I'm not sure we can totally tailor our recommendations to CDC at this point in time. The future will tell. That maybe, that is the same thing that can be adopted here. But at this point in time, I feel that we are still unsure. I would still go ahead and recommend no quarantine probably, but continue to use protective measures. And if you've had a significant exposure, then, maintain, do all the protective things. If you feel you're becoming symptomatic, then please go ahead and get tested. For healthcare workers, I know that, in fact, I think my husband also had a significant exposure in theater yesterday. So there is also certain anxiety as to what should be done. And I have a 12th grade person. My son is writing his 12th grade board exam. So we were all panicking a little bit. But my husband has been vaccinated. So I know that, the chances of him getting an infection is highly unlikely. But does it mean that he's not going to use a mask at home? Probably not. I would continue to ask him to use a mask at home. That is a simple answer.
Thank you.
I'm happy to hear other, thought processes. But this
Anybody
is what
has
I would
any
say.
other opinion?
I think the same thing, ma'am, like those who got exposure already vaccinated, we're not quarantining them. We are asking them to come for work, monitor for the symptoms, make sure that you follow all the precautions. That's what we are following here.
So during first wave, there was a lot of changes in the PP recommendation with respect to mask. So now we are much wiser after first wave. Is there any take on where should we, what about the surgical mask versus N95 mask, Dr. Vishnu?
Currently, we are using N95 mask in COVID ICUs and the COVID areas. All the COVID areas, we are using N95 mask. When it comes to the non-COVID ICUs, still we are using N95 mask because the people tend to intubate there, and at times if there is any COVID, that means they can get infected. When it comes to the other normal non-COVID wards and other areas, is the plain surgical mask.
Is there any role for double mask?
Double mask currently, I don't think there is any evidence to say that double mask is better over single mask in COVID. So as far as my knowledge goes, no.
Priscilla, you want to add anything on the data if you have on surgical mask versus N95 mask?
So we do, this is based on a small experiment that we had done in our hospital. This was in the initial stages when, there was a lockdown. We were not able to access PPE, and we had to control the usage of N95 masks because we had to reserve it for COVID. So what we had done is a small experiment. We had a 3D model, and what we did was we used a nebulizer to measure particle dispersion. What we found is surgical mask does reduce it by about 40%. And N95, we compared the venous mask and the other mask, which is the Halyard. Halyard was, of course, protective about 80 to 90%, and venous mask was about 60 to 70% or so. So surgical mask does protect. I think that is a very important message. In our experiment, when we did 2 masks together, we had absolutely no increase in protection at all when we used 2 surgical masks. So surgical masks do protect. If worn correctly, surgical mask is excellent. N95, the problem is people become a little lax just because it's so-called N95. And you can actually, most of the people don't even check their fit. So in that case, I would say that worn correctly, surgical mask is extremely good. N95 does protect, but it should be used in a scenario when you for possibly COVID ICU where there is a high aerosol generation, etc. So, but for an ordinary outpatient, surgical mask is good enough.
It's summer, and also, is there a requirement to use a hazmat suit, or if at all, where is it to be used?
Correct. So I think, initially, if you see, or if you remember all the pictures that we saw, initially from Wuhan and from the US, you saw everybody in hazmat suits. So I'm thinking back to my time in March when I was going slightly crazy in March and April, where everybody was demanding hazmat suits for everything. But I think now we have more data. As you know, WHO and CDC have come out with their recommendations where they believe that, the mode of transmission is mostly now droplet and aerosol generation rather than really, from inanimate surfaces. So at this point in time, it seems rather overkill to use hazmat suits everywhere. I think surgical gowns, which are disposable and fluid repellent, is more than enough at this point in time. I'm happy to hear from the others.
Dr. Nambi, I want to know the time. I mean, how
Probably
much time?
We have 4 or 5 minutes more, and then we can wrap up.
Yeah. Okay.
Yeah,
So
it's already 8:10.
Yeah. Moving on to the surgery in COVID-19 patients. So there'll be some patients who require surgery electively, who have just got COVID. What would be the recommendation, Dr. Vishnu?
For an elective surgery, I mean, first of all, I need to risk stratify what is the emergency for the surgery. I mean, if it's just a plain elective surgery, the Association of Anesthesiologists states that at least 7 weeks is what they have recommended. And American Association of Anesthesiologists recommended at least 3 months for severe COVID. For asymptomatic COVID, they recommended 4 weeks. And for symptomatic COVID, anywhere between 6 to 8 weeks is what is recommended for the elective surgeries. But when it comes to the semi-urgent surgeries, or where I think a clinically balanced decision has been should be taken. Discussing with the surgeon like how emergency is the surgeries. For example, recently we had a case of CABG who required surgery, so we try to clear as early as after 2 weeks, because after 2 weeks theoretically the shedding comes down. So I think for those sort of cases we need to we need to do a risk benefit stratification and then clear. But at least 2 weeks is what we do in those kind of cases. Yeah.
And now that people are getting vaccinated, if they are fully vaccinated, say for example 2 doses of vaccine, if people have received and they need surgery, do they need to be screened before surgery?
Yes, I think we should screen them before surgery, because the vaccine efficacy overall is 70% and 30% can still get COVID. And we know that those people who have COVID, if they undergo surgery, it is going to, the mortality is high. So one is to protect a patient from the consequences of doing surgery during an active COVID, number one. And number two, we can also, once if somebody is COVID positive and we perform surgery, we also post-op care also should be, we should place them in the COVID areas. So for that also we need to know the status before taking into the surgery. Yeah.
Thank you, Dr. Vishnu, for that.
Thank you.
So moving on to pregnancy, we have had patients who are pregnant getting infected, and then their course becomes a little tricky, especially if the COVID infection is towards their term. So Dr. Priscilla, would you like to say how the COVID-19 impacts pregnancy and the outcome? Is it a high risk for COVID-19 severity? And what are the consequences?
So I think there has been, initially there was not too much data, and I think what we did notice is it was not similar to the flu pandemic at all. But subsequently, so there was a lot of, everybody was quite happy that, it was not similar to the flu pandemic. But subsequently, we have now enough data from multiple observation cohorts all over the world. And if you remember, initially pregnancy was not listed as a high risk category, but it has been updated since. And pregnancy is now also considered a high-risk category. So what how is it that it impacts pregnancy? I think mainly preterm labor and stillbirths. Is it more common as compared to flu? We don't have that data available yet. It also predisposes them to, as you know, thromboembolic phenomenon. So we already know pregnancy itself is a thromboembolic inducing phenomenon. So COVID-19 just could it add on to that, and then maybe that is the reason that it goes on to preterm labor or stillbirths. We don't really have that information with regard to quantitative data, but observational cohort data does indicate that it can create problems.
What should be the mode of delivery in patients who are COVID positive or COVID suspect and term?
So I'm not sure there is, shall I say, robust data that, the mode of delivery should be any different. And whether it should be, should we terminate the delivery earlier or not? We don't really have the data at this point in time. So I think it should be dictated clinically. We do know that in severely ill COVID patients, of course, the whole situation changes completely. So in those cases, yes, to save the mother, I think we have actually opted for a cesarean delivery in those mothers. But otherwise, I think it should be dictated clinically.
Yeah, unfortunately, the cesarean sections have increased, and about 75% of pregnant mothers, pregnant ladies with COVID have been subjected to cesarean section. So what can they breastfeed the babies after delivery?
So that's an interesting question, and I think it reminds me to my HIV days. When we said we knew that it can be transmitted, but there was always this issue. Okay, should they die of diarrhea or should they die of getting HIV? So I think it really depends. It depends on the evaluation of the mother and how much she understands, and based on that, make a decision as to whether they can breastfeed their infant. There have been occasions.
Add here.
Yeah, Tanu, please go ahead.
Tanu, yeah.
You're the pediatrician, not me. So
and Foxy has actually come out with a statement that all babies born to COVID positive mothers should be roomed in with them and should be given breastfeeding, because the risk of postnatal transmission is less than 10%. And even if the newborns develop disease, it is very mild. So all of them have to go to their mothers and breastfed. Unless the mother is sick that she can't breastfeed the baby, or if the baby is sick that the baby needs NICU care, that's an exception.
What's the placental transmission risk, Tanu?
It's very less. It is less than 1%. Extremely low.
I think it's higher in the earlier trimesters, isn't it? So.
Thank you. We'll just have one last question because two participants have asked that question. Why is the second wave coinciding with the mass vaccination? And the second question is it related to vaccine? COVID-19, is it related to vaccine? So because there are repeatedly these questions are coming up. Why is the second wave coinciding with the vaccination, and why is it related to vaccine?
No, I don't believe that it is related to the vaccination at all. And it really doesn't make sense, right? The vaccination does not produce a live virus at all. So there is no way of transmitting an infection after having been vaccinated. So I don't think that is a consideration at all.
And also some people have a doubt.
Look at UK, because UK, they had a surge well before they started their vaccination program. So it is just serendipity or whatever coincidence that, both of these events have occurred together. Because there's that very viral WhatsApp message going around everywhere that, some top vaccinologist has said that, stop vaccination, otherwise you'll release a monster. And also, I would just urge the people not to believe in all that. It's sheer nonsense.
I agree, Tanu. I think that's very important. And all the disease pandemics that have occurred because of a respiratory illness, even if you look at the 1918 influenza pandemic, it lasted for 2 years with, multiple surges and coming down, going up, etc. So this is a natural course of a respiratory pandemic. And it's not the vaccination which has caused the surges. And I think, please do not believe, I'm not sure he's a vaccinologist if he said that, but please do not believe that at all. It's got nothing to do, the vaccine has got nothing to do with
and
the
there's
surges.
one question, whether vaccines can give rise to positive RT-PCR test.
No.
Some people have that doubt. Okay, thank you very much. I should really thank all the panelists for answering the questions so wonderfully, and also Dr. Tanu and Dr. Ram Subramaniam for joining us in the panel as well. Thank you very much. I should also thank the participants who have had fantastic questions, and they were actively participating, making this entire webinar and entire panel discussion very useful and worth it. Over to you, Dr. Nambi.
Thank you, Dr. Kavita, because Dr. Kavita said that she may not put up slides, but hats off to her. She put efforts to put up slides so that we had a good, coherent, neat understanding panel discussion. And it's been a good evening. We had around 325 participants through Zoom and around 100 participants through YouTube channel. And I thank all the faculty, starting from Dr. Kavita, Dr. Priscilla, Dr. Vishnu, Dr. Tanu, for being part of the panel, even though she could pitch in with a lot of answers relevant to pediatrics and pregnant individuals. Dr. Ram Subramaniam, Dr. Ram Gopal, all of them, but Dr. Bharat could not join. And all these webinar content will be available in our website, CIDS website, www.cidsindia.org. And these content can be accessed by logging in to the YouTube channel. All you have to type is CIDS webinar, and then if you're going to type in that, this content plus all the previous educational content that has been done on the society's behalf is available. The entire CIDSCon 2020 program is available in our website, and our monthly CIDS newsletter is available in the website. I make a fervent plea to clinicians in India who are interested in the field of infectious diseases. Please do join our society, the Clinical Infectious Disease Society, and probably we would come up with another activity depending upon the demand or what the audience want, probably in a month or two, and then or probably the COVID wave, how it goes in the country. And thank you, delegates, for always being responsive to very, very short notice, and of course the faculty for pitching in at the last moment, just like a T20 match, 5 days, and then they came up with beautiful presentations, sharing their experiences. Thanks a lot, and take care. Bye bye. I think the news is, I don't think we are running away, so we have to use mask. That is the fundamental thing. If you're going to run away from using mask, no amount of remdesivir, no amount of tocilizumab or the vaccine Covishield is going to help us. The basic fundamental thing is, unfortunately, India as a country looks into the West. We have to look into Far East. What South Korea, Japan, Taiwan, Thailand did is public use of mask, social distancing. So we have to focus on that. Of course, use vaccines. And that will be the final message from our society. Thank you. Take care. Be safe. And I personally believe that we got a busy 3 months ahead. Hopefully it ends by June, July. Let's hope for the best. Thank you.
Thank you.
Thank you. Thank you, Dr. Kavita. Thank you, Priscilla. It was good.